Unit 6, the nurse as manager of care, delegation, assignment, and prioritization. Unit 6 objectives. Distinguish the role of the professional nurse in assigning and delegating care to the licensed practical nurse and unlicensed assistive personnel. Outline the delegation and leadership responsibilities of the registered nurse. Describe the characteristics of tasks appropriate to delegate to unlicensed and licensed assistive device personnel. Please watch the following video on Not on My License.
Good morning, Pam. Becky, the charge nurse, said that you wanted to talk with me.
You are darn right I want to talk with you. Becky says that I have to work with that idiot nursing assistant Sandy today. I do not want to be responsible for someone else's actions. I am just too busy with my own work to check up on everything she is doing.
I understand that you are upset, but let me clarify a few things. You do not need to check up on every task Sandy does, but you do need to delegate appropriately and check in with her throughout the day. Sandy has been checked off on all the CNA skills and she is competent in every area.
What if she does something stupid? I don't want anyone else practicing on my license. I heard of an RN getting fired because a CNA got a patient up to the bathroom too soon after surgery and the patient fell and hit his head.
No one can practice on your license but you. That is a misnomer. If you ask the CNA to do something that is outside of her scope of practice, then, yes, you are accountable. But, if she does something that you have not asked her to do, such as get a patient out of bed, or give him something to eat when he is NPO, then the CNA will be held accountable.
But what if she don't tell me what I need to know? What if she does not tell me if Mr. Pieper's systolic blood pressure is less than 120? And I give him his antihypertensive erroneously? What then?
Try using direct, clear communications with specific expectations. You can say, please take Mr. Pieper's blood pressure before 8 a.m. and tell me what it is so that I will know whether I should hold his blood pressure medication. If Sandy knows why it is important to follow up with you, she will be more likely to work with you as a team. She will know why the tasks you ask her to do are critical to the care of the patient.
I thought I heard something. Well, what you say makes sense. I never thought about it like that. I guess I can try to work with Sandy today.
Thank you, Pam. I know I can count on you to do your part for the well-being of our patients.
Yeah. Whatever.
And Pam.
Yes.
Toward the end of the day, make some time to talk with Sandy about what went well and suggestions for working better together in the future. Ask Sandy for her suggestions and feedback also. Ask her if your directions were clear.
Okay, that is a good idea. Thanks for all your help.
My pleasure. I will check in with you later in the day to see how it works out for you.
Why delegation? This is a quote from the American Nurses Association position paper on delegation. As you can read, the question that it poses is, what do you suppose would be the most important thing for the nurse to consider when organizing care for the patient assignments? Expert nurses have discovered that the most successful method of approaching their practice is to maintain a laser-like focus on the outcomes that the patients and their families want to achieve. To attempt to prioritize, delegate, or assign care without understanding the patient's preferred results is like trying to put together a jigsaw puzzle without the top of the box that shows the puzzle picture. Not only does the puzzle player pick up random pieces that don't fit well together, wasting time and increasing frustration, but also the process of puzzle assembly is fraught with inefficiencies and wrong choices. In the same way, the nurse who scurries haphazardly without a plan unsure of what could be the most important life-saving task to be done first, or which person should do which task for a group of patients, is not fulfilling his or her potential to be a channel for healing. Determining care. So you would think, who gets what assignment? So you get report on two patients, and both of them have a blood pressure that is falling at the same rate. How do you decide which nurse should get that assignment? Which patient needs to be seen first, and which tasks can be delegated to assistive personnel? The key is knowing the preferred outcome for each patient. One patient is a young mother who is fighting for her life against breast cancer with chemotherapy. She is suffering uncontrolled emesis that has led to dehydration. She is expecting to regain her health and watch her children graduate from college. The other patient is a 92-year-old man who recently lost his wife to complications of repeated strokes and dementia. He has a history of severe heart failure and presented yesterday with a heart attack. He would like to die and join his wife. He has requested a DNR order and is awaiting transfer to hospice. You have a very experienced RN and a novice RN and several assistive personnel. Some are new, others are long-term employees. Which patient needs the more experienced care team and which can be handled by the novice nurse? The elderly gentleman is receiving palliative care, as he is a DNR who is going to hospice. The primary need for good people skills to support the primary need is for good people skills to support him and his family while they wait for transfer. This is an assignment that could easily be handled by the novice RN, while the young mother is best assigned to the experienced RN. If you did not know the desired patient outcomes, you might have reversed those assignments, which likely would not have been in the best interest of the patients, nor would it have been the best utilization of the skill set of your staff. Naturally, it's not always going to be such an easy call. Today, we will begin to explore prioritization, delegation, and assignment, tasks that are a very important aspect of RN practice. Assignment versus delegation. Assignment and delegation have close related definitions. The difference between the two is where the responsibility ultimately lands. The American Nurses Association and National Council of State Boards of Nursing issued a joint statement on delegation and officially defined both terms. Assignment describes the distribution of work that each staff member individually responsible for during a given shift or work period. Delegation is transferring to a competent individual the authority to perform a selected nursing task in a selected situation. With delegation, the nurse is still accountable for the delegated work. The RN must know that the chosen person to competently perform the task. Whenever a nurse delegates, he or she must also supervise. The NCSBN defines supervision as the provision of guidance and direction, oversight, evaluation, and follow-up by the licensed nurse for accomplishment of a nursing task delegated to nursing assistive personnel. Delegation. Delegation includes important leadership skills such as communication, collaboration with various team members, and conflict negotiation among those to whom the licensed staff member delegates. The NCSBN drafted a paper articulating the steps of the delegation practice. First, assess and plan the delegation based on the patient's needs and available resources. 2. Communicate. Communicate directions to the delegate, including any unique patient requirements and characteristics, as well as clear expectations regarding what to do, what to report, and when to ask for assistance. 3. Surveillance and supervision of the delegation, including the level of supervision needed for the particular situation and the implementation of that supervision, including follow-up to the problems or a changing situation. 4. Evaluation and feedback, in order to consider the effectiveness of the delegation, including any need to adjust the plan of care. The nurse needs to be familiar with each job description and confident about the competency of the work before assigning tasks. The authority and accountability for the outcome of the worker's performance still rests with the RN. However, the person who receives the task or duty is still accountable for accepting the delegation and for their own actions. If they are unprepared or untrained to do the delegated task, they need to say so and decline to perform that particular duty. They can't just do it and then blame the RN if they didn't have the experience to do it at all. You might wonder, isn't there a list that says what can and can't be delegated? That would be really cool, but because of the fluid nature of patient care, it is impossible to come up with a concrete list. What is safe to delegate in one situation isn't safe in another. Instead, you have to use underlying principles to make delegation decisions. The National Council of State Boards of Nursing published the 5 rights of delegation. Table 1.8 in your text covers this information. The nurse must delegate the right task under the right circumstances to the right person with the right direction and communication and the right supervision and evaluation. The right circumstance, patient conditions, and the desired patient results have to be considered, along with the rules and regulations of practice. The arena is another contributing factor. Delegation decisions in a long-term care facility will be very different from those made in an acute care facility because the patients will be very different themselves. The LPN might function as a team leader in a long-term care facility with just minimal oversight by the RN. But that wouldn't be appropriate in the PACU of an acute care facility hospital. The right task. In light of the 4 P's, purpose, picture, plan, and part, the right task is whatever the RN determines can be safely delegated given the patient's current condition, picture, and future preferred outcomes, purpose, if the nurse has a competent individual to perform the task. What is heard, especially for new RNs, is to let go of tasks because it's always going to feel like you are the best person to do it. But you have to realize there is only so much time in the shift, and you have to prioritize the best use of your time. You have to think, what other tasks and processes must I handle because I am the only RN on this team? Which tasks can be delegated based on the State Nurse Practice Act and what I know about job descriptions and hospital policies of this facility? How skilled are the personnel on my team? Who else might be available to help if needed? The right person. The hardest thing for you as a nurse to navigate is concern about knowing if you can trust the people in your delegation tree. What will help greatly is knowing the licensure, role, and preparation of your team members. You must also know their strengths and weaknesses. Naturally, that takes some exposure and experience in working with them. But you, as an RN, are working with float nurses, students, or any sort of temporary personnel. You have a duty to determine how competent they are by asking about their previous experiences and understanding of the work duties. It is also best if you can pair them with a strong unit staff member. Think of it in these terms. If your mother was a patient in the ICU and her nurse was an inexperienced float from the rehab unit, what type of assistance and supervision would you want that nurse to have from the RN? Right direction and communication. Use clear communication that can be plainly understood. A statement like, "Can you get the new patient?" doesn't really say much that will help the person understand what you are delegating. Be concise. Don't give too much information. If the student nurse wants to know how to set the pump to run at the desired rate, a lecture on fluid balance and electrolyte is not really needed. It's just going to waste time and confuse the issue. Use statements that correct, meaning that they are accurate. Follow rules and regulations, and consider job descriptions. Also, be certain that this is the correct individual for this delegation. Complete a frustration commonly voiced by UAPs and LPNs is that they would accomplish the task if the RN was clear about what was wanted and how to do it. You want to make the task list as understandable as possible. Don't forget to be clear about what you want, report back to you, and when. The right supervision. It is important to remember that supervision is an ongoing process. Make sure to get short updates from time to time so that you can offer suggestions or help as needed. Don't nag. Treat the team member with respect. Inquire, don't accuse. An example. It's 8:30 a.m. and the vitals are not in the electronic record. You can go up to the UAP, get in their face, and say, "It's 8:30. Where the hell are those vital signs?" It's certainly one approach, but it's not a good one, and it will definitely guarantee you won't have a good day with that team member. It is far better to try a less demeaning approach, such as, "I noticed the vital signs for the first 4 patients are not in the electronic record yet. Do you know what's been done?" Also, be sure to pay attention for opportunities to acknowledge the good things. The example given was, "You did a great job keeping up with cleaning Mr. Smith after his incontinence episodes. The family was really appreciative." It's also a good idea to check with the UAP to ask what can be done with the assignments to make him or her able to get the vital signs recorded before 8:30. Maybe something is going on with one of the patients that is very time consuming. and the assignment may need to be rebalanced. Getting feedback will go a long way with improving the effectiveness of your team. Delegating a task to an individual who is not competent has serious implications for the RN license, and the institute should the patient suffer an adverse outcome. The RN should assess the patient's needs and consider situations where the outcome is uncertain or the potential for harm is high. The RN should not delegate tasks under those circumstances. Nursing assessment and judgment are two things that cannot be delegated. Verify understanding. Once the decision has been made to delegate, the nurse must communicate clearly to the UAP and verify that the UAP understands the specific tasks to be done for each patient. When each task is to be done, the expected outcomes for each task, including parameters outside of which the unlicensed person must immediately report to the nurse, and any action that must urgently be taken, who's available to serve as a resource if needed, when and in what format, written or verbal, a report on the tasks is expected. A specific task that can be delegated to one UAP may not be appropriate for another UAP, depending on each UAP's experience and individual skill set. Also, a task that is appropriate for the UAP to perform with one client may not be appropriate with a different client or the same client under altered circumstances. For example, the taking of routine vital signs may be delegated to the UAP for a client in stable condition, but would not be delegated for the same client who was becoming unstable. The unlicensed person who receives the task can't delegate it to someone else. Even if the task is one that may legally be delegated, it has to go back to the nurse for the nurse to determine if the task can be delegated to a particular UAP for a specific client. In addition to delegating to UAPs, the RN also delegates to the LPN. Because LPNs are licensed, the nurse must know their state-specific scope of practice in order to delegate effectively. In some states and facilities, LPNs may perform tasks generally considered the role of the registered nurse if they have received special training. For example, in most U.S. states, they may assess intravenous IV infusion sites, but in only some states can they mix IV solutions and give IV push medications if they cannot delegate to others, and they cannot delegate to others. The RN may delegate components of care, but does not delegate the nursing process itself. The professional practice functions of assessment, planning, evaluation, and nursing judgment cannot be delegated. The RN also delegates to other RNs. This is part of the daily routine of determining which of the available nurses should care for which clients or when specific additional assistance is required for one client. Which tasks to delegate? As a general rule, LPN education is designed to handle stable patients with predictable outcomes. When it comes to IVs and LPNs, it varies from state to state what the LPN can do. Since NCLEX is a national test, your questions won't deal with a state-specific issue. You just want to look at the patient in a given scenario and think about who is stable and unpredictable, or who's predictable, with tasks such as routine wound care, routine med passes, etc. UAPs can do ADLs and routine vital signs. As the nurse, it is important for you to reflect on what you need to do each day and trust your instincts, such as not delegating to UAPs when you feel something is not right with your patient. Make sure you get a good report from the previous shift and actually eyeball each patient under your care before delegating. Consider the patient's diagnosis, whether the patient has been stable, if the patient has additional needs, or if there are any pressing family issues that might affect care. Give the UAP a detailed report, including precautions. Make it clear that you will be available and also what needs to be reported to you immediately. One thing that many nurses do, which is dangerous, is to rely on hospital policy to decide when and what to delegate. Legally, it is not the hospital that has the authority in this situation. Rather, it is the State Nurse Practice Act, and you have to know what the Act allows. Know also that since the nurse remains responsible for all tasks that are delegated, you cannot delegate a task that you cannot complete correctly yourself. If you don't know how to do it, you can't tell someone else to do it. Co-delegation tasks. Okay, so LPNs get chronic, stable patients with predictable outcomes. A popular one is COPD patients. Patients who are 24-hour post-op, they will not be able to do any discharge planning. They cannot do any admission assessments, including admission vital signs and IVs. They can give narcotics, have patients 72 hours after an MI, have patients with a CVA, have patients with on vents or with low coma scale after 1 week's time. They can do sterile procedures. They can give meds, but nothing IV push. They can complete the nursing process under the direction of the RN. They can work with contagious patients. Think of patient assignments. They can all be delegated to the LPN. Can reinforce teaching, but the RN has to do the initial teaching. UAPs. UAPs work with stable patients. They make beds, provide water, give enemas, obtain stool specimens, monitor INOs. They transport patients from one place to another. They can feed chronic Parkinson's patients. They can care for chronic CVA patients. However, they do not let a nursing assistant feed anyone who is an aspiration risk. So if your chronic CVA patients can't swallow well, that's not a patient that your UAP is going to feed. Vital signs on a stable patient can do vitals half hour after a blood product has been started. They cannot do admission vitals. They cannot perform any sterile procedures. They cannot provide or give any type of medication, even over-the-counter topicals. They cannot do any teaching. They cannot work with PT, with providing help, assisting to walk the patient. They cannot do any patients that have an arterial line, that have a trach, that have ET tubes, vents, or that are have any contagious diseases. They can assist the RN in whatever duties that the RN may need her for. They can remind and reinforce. Usually They can remind the patients to do something rather than how to do it. So they can remind the patient to do incentive spirometer that the nurse taught them how to do. Usually, in regards to ADLs, they can perform oral hygiene, they can provide nutrition, they can help to ambulate a patient to the bathroom and back. If the patient is already ambulatory, they can provide skin care. They can do hourly turning, repositioning, cough and deep breathing. They can provide passive range of motion to these patients. They can also help put the patient in special positioning that might be needed, but this is going to need to be initiated by the RN, and then the UAP could then continue it. So they can assist with it but not teach it. They can do chart eyes and nose, vital signs, weights. They can detach the suction and remove a Foley, but cannot connect or insert a catheter. And that's going to be specific to the hospital policies. In some hospitals, UAPs can insert the catheter, Foley catheters, especially Baycare hospitals. Stay away from options asking to show, explain, monitor, teach, check, assess, and demonstrate. Those are all words that you want to stay away from, especially with the UAP, all outside of the scope of the UAP. So any ADLs or non-invasive stuff is really what you want to stick with. Avoid these assignments for any new float, any LPN, any traveler. These assignments you're going to avoid for these specific personnel, and it's going to be new onset or sudden or acute situation occurring with a patient. A new admission should not be done by any of these personnel as well, or a transfer to a higher level of care or a different facility of care should not be delegated to one of these personnel as well. LPNs and UAPs cannot date. Date is used as an acronym. D is for delegate, A is for assess, T is for teach, and E is for evaluate. So here's an example case. Sabrina's an RN in a busy med-surg department at a hospital in Miami. She's in the middle of passing morning medication when her new post-op patient, Mr. Winters, rings in complaining of severe pain. When she arrives to Mr. Winters' room, Sabrina performs a focused assessment on his surgical dressing and finds everything within normal limits. Sabrina consults the electronic medical administration record and sees that Mr. Winters has IV morphine ordered for severe pain. She also recalls the report from the PACU nurse stating that Mr. Winters' blood pressure was running low. In reviewing the tasks at hand, Sabrina knows she needs to continue with medications for her other patients, to get a new set of vitals on Mr. Winters to be sure his blood pressure won't bottom out with a new dose of IV morphine, and then to administer the pain medication to Mr. Winters. In order to accomplish her tasks in a timely manner, Sabrina determines that it is necessary to delegate something to the appropriate assistive personnel. She remembers that Martha, a PCT, has also been assigned to her patients. Sabrina contacts Martha to see if she is available to take Mr. Winters' blood pressure, knowing that taking patients' vitals is within Martha's education and training and is part of her normal assignment as a PCT. Sabrina indicates to Martha that she will continue passing medication while Martha gets the patient's vitals, which she should carry out right away. Sabrina informs Martha that she will be with the patient in the next room by the time Martha has the vital signs. Martha agrees and begins to take Mr. Winters' blood pressure. Martha finds Sabrina as she is coming out of the room next door and reports that Mr. Winters' blood pressure is 118 over 68, which presents no contraindication to administering the IV morphine. Sabrina goes to the department's med room to obtain the pain medication and administers the morphine, relieving Mr. Winters' pain. She thanks Martha for her help and then returns to her other patients. In summary, delegation skills are developed over time. Nursing employers need to recognize that a newly licensed nurse is a novice who is still acquiring foundational knowledge and skills. In addition, many nurses lack the knowledge, the skill, and the confidence to delegate effectively. So, ongoing opportunities to enforce the theory and apply the principles of delegation is an essential part of employment orientation and staff development. Many nurses are reluctant to delegate. This is reflected in the NCSBN research findings and a review of the literature, as well as anecdotal accounts from nursing students and practicing nurses. There are many contributing factors, ranging from not having had educational opportunities to learn how to work with others effectively, to not knowing the skill level and abilities of nursing assistive personnel, to simply the work pace and turnovers of patients. At the same time, NCSBN research shows an increase in the complexity of the nursing tasks performed by assistive personnel. While the demographic changes and resultant increase in the need for nursing services, plus the nursing shortage, nurses need to support the nursing assistive personnel. They need their support. Delegation can be an extremely useful strategy in providing thorough and effective nursing care. Skill in delegation, however, must be learned and developed over time. The nurse should not hesitate to consult with others regarding the appropriateness of delegation. Delegation is a process that, used appropriately, can result in safe and effective nursing care. Delegation can free the nurse for attending more complex patient care needs, develop the skills of nursing assistive personnel, and promote cost containment for the healthcare organization. RNs are urged to seek guidance and appropriate direction from supervisors or mentors when considering decisions about delegation. Mastering the skill and art of delegation is a critical step on the pathway to nursing excellence. Your text has very useful delegation decision boxes in many of the chapters that are linked to the content of that chapter. This is an example from the assessment chapter. Remember, LPNs and UAPs may not date. Prioritization. Prioritization is the process of deciding which needs or problems should get immediate action and which ones can be delayed because they are not urgent. It is a two-part process. You have to have a clear idea of the desired patient outcome you are aiming for, but also you must have the ability to weigh possible tasks and rank them in order. When ranking them, you have to look at how long the task will take, how the task is related to the outcome you are trying to achieve in your patient, and what could possibly happen if the task isn't completed, including possible problems that could occur. This can be really hard for new nurses because until you have worked with enough typical patients having that particular disease or process, it is really hard for you to predict what might happen. You have to know the purpose for care, current clinical picture, and a picture of the outcome or results in order to plan priorities. Those principles form the framework for the registered nurse to make the decisions for assignments and delegating. They can be referred to as the 4 P's: purpose, picture, plan, and part, which would be the parts each team member is assigned or delegated. So, how do you prioritize? One way is to carefully evaluate each task using the following criteria. Is it life threatening or potentially life threatening if the task isn't done? Would another patient be endangered if this task is done now? What about if it is left for later? Is this task or process essential to patient or staff safety? Is this task or process essential to the medical or nursing plan of care? You can then begin to set priorities. Believe it or not, the foundation you learned in level 1 works to form the basis for the 3 levels of priority setting. ABCs plus V: airway, breathing, cardiac status and circulation, and vital signs. Concerns such as mental status changes, untreated medical issues, acute care, acute elimination problems, abnormal lab results, and risk. Any health problems or other than those already included in the first 2 levels, such as rest, coping, long-term issues in health education, and things like that. So here's a question. The nurse is caring for a diabetic patient in the ambulatory surgical unit who has undergone debridement of an infected toe. Which task is appropriate for the nurse to delegate to unlicensed assistive personnel? A. Check the patient's vital signs. B. Monitor the patient's pain level. C. Assess the patient's IV catheter site. And D. Evaluate the patient's fibial and pedal pulses. So, what do you think? A. Check the patient's vital signs. So, why do you think this is the correct response? Well, doing vitals is part of a UAP's scope of practice. Okay, so here's another question. Identify the 5 rights of delegating nursing care. Select all that apply. I know you hate these. So A, right time, right task, right patient, right person, right dosage, right circumstances, the right supervision and evaluation, and right directions and communication. Now think about it. Okay, so your answers are the right task, the right person, the right circumstance, the right supervision and evaluation, and the right directions and communications. Now remember, the trick was that we incorporated in there your 5 rights to safe patient medication administration in there too, and that was a little tricky. Okay, so here's another question. Identify the 5 rights of delegating nursing care. Select all that apply. I know you hate these. So A, right time, right task, right patient, right person, right dosage, right circumstances, the right supervision and evaluation, and right directions and communication. Now think about it. Okay, so your answers are the right task, the right person, the right circumstance, the right supervision and evaluation, and the right directions and communications. Now remember, the trick was that we incorporated in there your 5 rights to safe patient medication administration in there too, and that was a little tricky. So here's a video on Delegation 101. Tell us what you think.
Hi, welcome to Nursing Delegation 101. In this training session, you will learn what delegation is, how and when to delegate, and what procedures we can and cannot do. First, let's learn some terms. Controlled acts. Acts that are seen as potentially harmful if done by an unqualified person. Scope of practice. The roles and responsibilities that an authorized, competent healthcare professional can perform.
Which controlled acts can be done and to whom? Both registered nurses and registered practical nurses are authorized to procedures below the dermis or mucous membrane, administer a substance by injection or inhalation, put an instrument, hand or finger beyond the ear canal, nasal passages, urethra, labral majora, and dispense a drug.
So we know what can be done or is authorized to RNs and RPNs, but what about initiating a procedure under the controlled acts?
RNs can initiate procedures such as wound care below the dermis or mucous membrane by cleansing, soaking, irrigating, probing, debriding, packing, or dressing, and venipuncture to establish peripheral intravenous access and maintain patency when the client requires immediate medical attention, as well as procedures that involve putting an instrument beyond the client's nasal passages, larynx, or opening of the urethra, as well as an instrument, hand or finger beyond the individual's anal verge into an artificial opening into the client's body or labia majora. On the other hand, RPNs can initiate wound care below the dermis or mucous membrane by cleansing, soaking, or dressing, and for the purpose of assisting with health management activities, a procedure that involves putting an instrument beyond the client's nasal passages, larynx or opening of the urethra, a hand or finger beyond the labia majora, an instrument or finger beyond anal verge.
Now, we know what controlled acts can be authorized and initiated by RNs and RPNs according to their scope of practice. But what is delegation? Delegation is a formal process where the delegator, usually a healthcare provider who has the authority and competence to perform a controlled act procedure, delegates or hands over the authority of the task to a delegatee, who is another individual or care provider.
Take note, nurses can delegate and accept delegation if they are registered in the general, extended, or emergency assignment classes, can only delegate acts that they are authorized to perform, and only accept delegation from regulated health professionals. RNs and RPNs cannot delegate the controlled act of dispensing a drug. Remember, a nurse who delegates a controlled act is responsible for the decision, cannot subdelegate a task already given to them, and delegation can be oral or written, with appropriate specific aspects of delegation to be recorded. See CNO's authorizing mechanism documentation. How about delegating to UCP, or unregulated care provider? For procedures below the dermis or mucous membranes, family member or member of household or other paired care providers are required delegation according to CNO's Working with Unregulated Care Provider 2013 document. However, go by institution policies. Always refer to CNO's delegating guidelines and your institution policies. Now, let's effectively delegate. Here are 6 steps for effective delegation. Step 1. Deciding what to delegate. Consider, what is your scope of practice? What controlled acts are you authorized to do? If you cannot answer these, check your hospital policies and refer to CNO's 2015 authorizing mechanisms. Step 2. Select the delegatee. Consider, is the delegator a regulated or unregulated health provider? Is the delegatee's skills sufficient for the task, or is extra training needed? If you cannot answer these, refer to CNO's authorizing mechanism or working with unregulated care providers or your hospital institutions. Step 3. Delegate task. Consider, does the task meet the 10 requirements of delegation? Can you describe the task in detail and offer an explanation for selection? If you cannot, refer to your institution policies and CNO's 2015 authorizing mechanism. Step 4. Assess and discuss. Consider, are both delegators and delegatees involved in the delegation process? For the delegatees, how might learning new responsibilities affect overall workload and what levels of authority are involved? If you cannot answer these, refer to your hospital policies or the CNO documents. Step 6. Completion of the task. Consider, evaluate, what are the team's successes or shortcomings of the completed tasks? Refer to your hospital policies and CNO documents. Congratulations, you have effectively delegated. For more information, see the delegation documents with College of Nurses of Ontario, the Regulated Health Professionals Act, and your institution policies. Thank you for watching.
Created using Powtoon.